Onc Live Insights is a video editorial program produced by Onc Live.
What we know about maintenance cytotoxic chemotherapy is that it provides a survival advantage for our patients with advanced stage non-squamous non-small cell lung cancer. And based on many studies, the only cytotoxic chemotherapy that has shown a survival advantage in phase 3 studies has been pemetrexed. And my approach to maintenance really tries to mirror the data. And the data suggests that patients who receive 4 cycles of a platinum pemetrexed-based regimen, who've at least achieved stable disease, should be offered maintenance therapy. And we know that that strategy prolongs survival. I think we have to put survival gains in the context of the lung cancer landscape and understand that only 5 to 10% of studies in lung cancer, advanced stage, ever show a survival advantage. And we have several studies showing that PEM-based regimen does provide a survival advantage. I think the discussion regarding maintenance has to begin at the initiation of therapy.
Over the past decade, we've had a number of trials that have shown that we can improve progression-free survival and in some cases overall survival with maintenance therapy. Now remember, a decade or so we didn't have drugs that we could give for a longer or protracted time without significant toxicity such as myelosuppression or neuropathy. With the advent of pemetrexed, we have good level data that shows platinum and pemetrexed followed by pemetrexed maintenance improves progression-free survival and overall survival with modest toxicity. The toxicity is real. It's about 10% of people have fatigue. There is myelosuppression. There is some renal toxicity that most of us encounter. But many of us who treat patients with non-small cell lung cancer have had patients who've been on maintenance pemetrexed often for 1 to 2 years with good tolerance.
We often offer 4 to 6 cycles of platinum-based chemotherapy to patients with stage 4 non-small cell lung cancer, and that will yield the survival benefits that had been shown in previous clinical trials. Following those 4 to 6 cycles of platinum-based therapy, however, many patients are still candidates for additional or subsequent lines of chemotherapy. And those lines of chemotherapy can either be given as second-line therapy, where there is an intervening rest period between the frontline therapy and then the subsequent therapy, or as maintenance therapy, where the initial 4 to 6 cycles of platinum-based therapy are immediately followed by additional cycles of usually single-agent cytotoxic therapy. You've heard from my colleagues about the different types of maintenance chemotherapy, whether you use it as switch, meaning you switch to a different agent at maintenance, or whether it's continuous maintenance, where you use the same drug that you had used in the frontline setting and just treat those patients until they progress. The general principle for maintenance chemotherapy is that it is really not the maintenance chemo that prolongs progression-free survival or prolongs survival or improves outcomes in this disease. I think a lot of us tend to think of maintenance chemotherapy as a fixed recipe for our patients. The concept that I'd like our colleagues to remember is that maintenance therapy really works because it provides the patient with active therapy after their frontline treatment. Maintenance therapy works because those patients get exposed to additional lines of active anti-cancer therapy that they would not have received if they just went on observation alone. Which is also the reason why second-line therapy is also highly active, because it offers that patient additional systemic therapy that they would not have received if they just received best supportive care alone following their frontline therapy. So in the conceptual viewpoint that I look at maintenance therapy in, one can just think of maintenance therapy as early second-line therapy, meaning you're providing active anti-cancer therapy earlier in that disease course.